webinar of the fall season, brought to you by the Early Career Immunologist Committee at CIS. My name is Andrew Snow. I'm at Uniformed Services University in Bethesda, and I'm joined by my fellow moderators, Shanmuganathan Chandrakasan from Emory and Monica Lawrence from University of Virginia. And I just want to thank USIDNet, as always, and LACID for their generous support to bring this webinar series to you. A couple of reminders for those that are joining us tonight. As we go through our two very interesting cases, please ask questions through the chat box that you see on the left bottom side of your screen. And as always, we're looking for more great cases to present in subsequent webinars, so please reach out to us. We always need new and interesting cases. So tonight we'll also be trying something a little bit different. Rather than starting the webinar with our typical literature review, we'll start with our first case and run through that, as well as the second case, and then I'll come back and do about a 10-minute presentation on some of the key diagnostic immunology laboratory tests that we associate with diagnosis of the cases we'll talk about today. So I hope everyone enjoys that. So to start off, we have our first case comes from Dr. Eduardo Finger, who's the head of research and development at SalomaoZoppi Diagnostics in Sao Paulo, Brazil. And we're very pleased to have as our senior mentor for this case, Dr. Daniel Kastner, who's the scientific director of the National Human Genome Research Institute at NIH. So I will now turn it over to my co-moderator, Monica Lawrence.
All right, thanks, Andrew. So I'm going to let Dr. Finger go ahead and start with the case. We will pause after he presents a few slides to get some differential from the chat room. So be ready to throw out your ideas there, and then we'll let him continue and then hopefully have a good discussion about it. There's a lot of intriguing points about this case. Dr. Finger?
Well, good evening, everyone. Just thank you first of all, thank you very much for the invitation. And just for starters, I'll provide you the context in which I'll present the case. So there are three parts to this case. The first one is what happens before admission to the hospital, which was built by interviewing the family. The second happens inside the hospital, where he was admitted for several months, where everything went wrong. And then finally they found a diagnosis. The family was broken, financially and itself, like the parents divorced and everything. And they couldn't afford private medicine and private doctors anymore, so they came to me. So I received the case because I was in the network doctor. So I started following the case after he was discharged. So this case is about a boy, Middle Eastern and Mediterranean extraction, that was born in '88, and from the moment he was born, he started having inflammations. First, he had kidney infection. Can you see the slide? Oh, now I can. So he had BCGitis, and everything in his lymphoid tissues was denominated giant adenoids. When he had appendicitis, it was a giant appendix. But other than that, he was considered normal. He had many doctor's appointments with the pediatrician, but no one thought they should investigate it further. Just a random guy with lots of inflammation. Until 2006. In 2006, he was feeling a bit sick with diarrhea and a little bit of back pain in the genital area. And he took a non-steroidal anti-inflammatory drug and started having ecchymosis all over the body and bleeding through the gums and through the nose, and he was rushed to the hospital, where he arrived with 7,000 platelets. And this was completely out of the blue. No one expected anything like that. In the hospital, the person who took care of him was a hematologist, and he basically tried to treat this as a idiopathic thrombocytopenic purpura, but he had several other signs and symptoms that made it difficult for him to make this diagnosis. So basically stabilized him with IVIG and prednisone and discharged him for an infectologist for further investigation, like saying, oh, don't come back to me, right? So he spent the next 5 months to a year with this infectologist, where he was investigated for everything in the book, and no one got an answer. And he had at least 5 other admissions in this period where he had bleeding and pain and diarrhea and epididymitis. In 2007, the end of 2007, without any answer, they decided to treat him empirically for tuberculosis. And because it did not work very well, he had several side effects from the treatment, and he was a teenager, basically. In 2008, he decided, I don't need doctors anymore. I'm not taking any more medications. I'm done with it. And his mother tells me that he started to decline, like he had one day inflammation here and one day pain there, a bit of fever, until 2009, January 2009, when he started having high fever, vomits, and he was taken to the hospital, admitted for something that was considered sepsis at the time. And he was treated with several combinations of antibiotics without any results. He continued to decline. And every single exam I know was performed on him for every possible pathogen. Mm-hmm. Everything came negative, like you're going to see later on the exam table. Finally, they managed to get a combination of antibiotics and immunosuppression that he began to get better from the lungs. But then he had seizures, unremitting seizures. He had to be put in induced hibernation and continuous electroencephalographic monitoring and intracardiac pressure monitoring. And he stayed like that for 10 days. It was performed a brain biopsy and cerebrospinal fluid examination. And basically what they found was acute diffuse encephalomyelitis, but no pathogen was found. Nothing that could lead to a diagnosis was found. And this was all reconstructed from the records, so I don't actually know what the doctors were thinking then. I only can see the confusion in the notes that people didn't really know what was going on. And at some point in the diagnosis inside the intensive care unit, somebody wrote ALPS, acute, lymphoproliferative syndrome, autoimmune lymphoproliferative syndrome. Okay.
So I'm going to interrupt you there, and you've thrown, Dr. Finger. Let me stop you there, and let's let the audience kind of throw out any other thoughts. So you mentioned a diagnosis of ALPS was somewhere appeared in the chart. Does anybody else have some other thoughts that might be consistent with this patient's presentation? So we have a patient with a lot of inflammation in early childhood, thrombocytopenia, lymphoproliferative disease, and then now this recent presentation. Anyone want to come up with a different differential? So while you guys are thinking about that, we have a question from the audience for you, Dr. Finger. Any history of hearing loss or rash?
No. No hearing loss, no rash, no arthritis.
Okay. All right. Okay, so we've got some people throwing out LRBA or CTLA-4 deficiency, thinking about maybe the autoimmunity component, which is a good thought. Anybody, and we'll give a couple more minutes for anybody else to throw out. Anybody got any ideas about this BCG-itis that, and the reactions with the tooth loss, the lymphoproliferation? Some people in the audience are asking about fevers. Any fevers?
Yes, he had fever, several instances all the time.
Is that constant fever? Okay. All right. So we have a suggestion. Episodic fever. Okay. All right. And can you broaden the infectious history out from what you could gather? Anything infection-wise, pneumonias, viral infections, salmonella infections, anything else?
Until his admission to the hospital, the most I could gather about infections that he had a very severe episode of molluscum contagiosum. And he had a bit of herpes, especially herpes simplex, and that's it. There's no story of recurring pneumonias or anything like that.
Okay, all right. Well, Dr. Notolandro is a little bit puzzled by the inflammation, saying that doesn't really fit with ALPS. We've got a few other suggestions of defects. We have NLRC4 was raised, DOC8, ADA2, and STK4. So we're starting to come up with a differential. So we'll let you keep going and see what we have from there.
Someone wrote lymphopenia. Yes, there was lymphopenia. And actually, I don't know where the diagnosis of ALPS came from, but right after the diagnosis, there's a note from an immunologist that I know and I respect very much, and he was commenting on that. So probably he thought about it. And I think ALPS came from the fact that there was nothing they were doing that could work there, that was working there. So someone threw the diagnosis. And they pursued it. And can I advance the slide? Okay?
Sure.
Okay. So they tested for double negative TCR alpha beta T cells and apoptosis. And actually the test I'm going to show in the next slides, it came with 6% double negative T cells, even though he was lymphopenic, and a significant reduction in apoptosis compared to a control. When they got these results, they changed from infection to focusing only on immunosuppression. So he received several bouts of pulse therapy with cyclophosphamide, with prednisone, and IVIG, and he started to improve. So it took him a month until he was able to be discharged, but he was discharged, and once he was discharged, he was genetically tested for ALPS-related mutations. First, just the FAS gene, which came normal, and later, the whole package with FAS, FAS ligand, caspase 10, caspase 8, NRAS, KRAS, everything came negative. At this point, he came to me, and when I received him, he came with diagnosis of ALPS, which was very important to that family because they had spent a lot of time not knowing what's going on there, with him almost dying, and it was very sensitive. And when I received him, he was a very battered person. I mean, he was weak, he was thin, almost a destroyed organism. But whatever they did now was working. He came to me with prednisone, azathioprine, and 150 milligrams a day, and the infusions of IVIG. And since it was working, I decided just to provide him stability and continue the treatment and trying to diminish the azathioprine as much as I could, as long as the platelets continue rising, the C-reactive protein was stable, and it was very easy to control him with C-reactive protein. If it goes up, platelets go down, and lymphocytes go down. He was very lymphopenic. In the beginning, I put him on prophylactic antibiotics, but then I realized he didn't need that, and I removed him from the antibiotics, and nothing happened. He was very well. And he started to improve up to a point. In the beginning of 2010, he had a magnetic resonance imaging of the lower limbs, and we detected he had massive necrosis of the bones there. So we put him on crutches and rest. He stayed 2 years like that, but we kept the regimen stable because he was continued to recover with some fluctuations. And he recovered, and he was okay. And then he came to me and said, you know, coming to the hospital every month is a pain. I want you to space away these infusions. And since he was okay, instead of every 4 weeks, I decided to try every 5 weeks. On the first time I tried to space away the infusion, had a seizure, had to go to intensive care. So that was, I told him, that was the last time you talked to me about spacing away pain. And we kept going from there every 4 weeks, an infusion. And azathioprine, I was able to lower it to 75, and then he had some fluctuation. The platelets raised it to 100 again. And basically he became a normal human being again. Very well, normal life. And then it was the time to find out, okay, what's going on? Everything we tested came negative. So I decided to order, the family had money again, decided to order the whole exome sequencing to test. And came this combination this combination right here, I don't know if you can see the arrow. Can you see my arrow on the table? If not, it's okay. The mutations identified by whole exome analysis. So he came with a mutation in NOD2, right? A mutation in MEF, and another in caspase 8 AP2. Now that I had the genes, I had the mother, the father, and the sister. So I decided to take the sequences of them. So the mother came with 2 of the mutations, the father with 1, and the sister with another. They are completely asymptomatic. They have absolutely no symptoms. Just going to the previous slide, these are the basic pertinent labs. So before 18, his labs are unremarkable. And after that, what you can say is that he has persistent thrombocytopenia. He averaged between 10 and 30,000 in the beginning, and now he's in 120,000 stable. The liver and renal profile, they fluctuated whether the inflammation was high or low. Currently, they are normal. These are the pathogens he was tested for, right? Everything on the book, and they all came negative by every technique they tried, molecular techniques, serological, microbiological, immunohistochemistry. The autoimmune exams also were non-informative. He had several biopsies, like a bone marrow biopsy was normal. The ileum biopsy, he did not only ileum biopsy, he did a video capsuloscopy, which basically said there was enlargement of the lymphoid tissue in the ileum and in the whole intestine. The ileum biopsy came with its chronic ileitis, moderate inflammatory activity, liver biopsy, diffuse inflammation also without granulomas, brain biopsy, diffuse areas of macrophagic infiltrates, and acute diffuse encephalomyelitis.
All attendees are muted and may unmute themselves by pressing *6.
Okay. I just received a message. Did anyone else receive it also?
That all...
Hello?
Hello?
You are there?
Yeah, go ahead. Keep going.
Okay. So the facts that people rely to give him diagnosis is this. So the double negative CD40 cells, he had 6%, right? He was lymphopenic, but we have to say that. The apoptosis test showed that he had the 16.8% compared to 25.3% of the control. He had normal vitamin B12. He had enlarged polyclonal gamma globulins. And I just received yesterday a new exam, fax exam, where now normal. He had 3.8% double negative T cells, and he's not lymphopenic anymore. Now he has normal lymphocytes. Okay? So basically, this is what I wanted to tell, and now I don't know if you want to open for discussion, if you have further questions that I can answer.
Yeah, sure. So let me try to bring Dr. Kastner in, if you want to give your thoughts about the case, Dr. Kastner.
Well, I certainly think it's a terrific case, and I think that Dr. Finger should be congratulated on really a wonderful presentation. And I think that certainly just by virtue of the fact that this patient has improved dramatically, that at least the clinical assessment of the patient has been on target in terms of developing a therapeutic approach for this patient. As far as the question of the genetic testing, and I'm sure that we'll discuss this in more length as we go through the case further, I think this is going to be an area where we will have to think about what is the real meaning of the variants that have been identified on whole exome sequencing. So certainly the one that, the gene that I'm most familiar with, just because of the fact that my lab has worked on it for a number of years, is MEFV, the gene mutated in familial Mediterranean fever. And the variant that is listed there as being a mutation identified in this particular patient, listed as in its nomenclature as a cDNA change, 2080A to G, translates into the substitution of valine for methionine at position 694 in the protein. So that is probably the most severe of the mutations that's associated with FMF, with familial Mediterranean fever. And it is a mutation that's found commonly in certain Middle Eastern populations. And so that goes along with the story that we've heard in terms of his ethnic background. It used to be thought back when we first discovered the gene for FMF that you had to have 2 mutations at the FMF locus in order to have clinical disease. We now know that sometimes in about a third of patients with clinical FMF that in fact there's only 1 demonstrable mutation, and certainly M694V is one that we frequently see as the sole mutation, seen only on 1 chromosome in patients that have clinical FMF. Now, I'd hasten to say that the clinical picture that this patient presents with is not familial Mediterranean fever. There's absolutely no way that based on the clinical story that Dr. Finger has so nicely presented would anyone jump to the conclusion that this patient has FMF. But it could actually be that having a single mutation at the MEFV locus could have clinical consequences. The usual clinical consequences would be recurrent fever with serositis or arthritis or rash, and sometimes the development of amyloidosis. With regard to the other 2 variants that have been identified in this patient, the variant at NOD2, which of course is the gene that is mutated, also known as CARD15, that's mutated in Blau syndrome, and variants of which are associated with Crohn's disease. That particular location where the variant is seen would result in a change in the protein of the substitution of glycine for arginine at position 703. And that's right next to position 702 is a location where variants associated with Crohn's disease are oftentimes seen. The 703 location, this particular variant is one that's rare in the databases, and at least based on computational assessment is probably benign. Of course, the question is whether the combination of this NOD2 variant, the MEFV variant, and then the caspase-8 AP2 variant or variants might lead to the clinical picture. And of course, that's something that's very hard to know for sure, at least based on the information that we have so far. The reason why it's hard to know is as Dr. Finger has pointed out in his written materials, there are no other patients that have this combination of mutations, and certainly the power of exome sequencing now allows us sometimes to find patients that have these unusual combinations. Of course, there may be other variants in the genome that wouldn't be so apparent, that wouldn't attract our attention because they haven't been associated with particular inflammatory or autoimmune diseases that might also be relevant to this. And so certainly that remains an issue that remains unresolved at this point. So those are my comments with regard to at least the genetic analysis on this patient.
Thank you so much, Dr. Kastner. We have probably just 1 or 2 more minutes for the case, even though I know it's raising lots of questions. If there's anything in the audience, anybody have any questions or thoughts about this kind of ALPS, autoinflammatory syndrome overlap case, I'd welcome you guys to send those in. Otherwise, if we don't hear anything from the audience, we'll move on to the next case. So I'll give the audience another minute or so. If there's anything you guys want to chime in, are you convinced this is ALPS? Are you convinced this is autoinflammatory? You think it's a brand new disease that we should call Finger syndrome? What is everyone thinking?
I'm always against eponyms.
Okay, all right, so not that one. All right. So Dr. Goodman wants to know from you, Dr. Kastner, about heterozygous MEF-V patients, and do they improve clinically with age? So could this improvement be not the treatment, but just him getting older?
That's a great question, and in our experience, not necessarily do patients who are single mutation patients, heterozygote patients, get better with age. There's maybe a little bit of tendency towards milder disease, but even that, you can't really be sure, and I think that this case illustrates the fact that so much is entailed in what is the background, what's the genetic background, and if someone happens to have other genes that co-conspire with the MEF-V gene, then you might have actually still serious disease.
Okay.
Dr. Kastner.
Pardon me?
Sure, go ahead, and then after that, we have a comment from Dr. Notarangelo, and then we have one more question, and then we'll end there and go to the next case.
Okay, so the fact that he's on azathioprine for so long bothers me. So my question is, do you think I could ever switch that for colchicine? Would it work?
Yeah, that's a terrific question. And as I was reviewing the materials before the webinar, I was actually thinking the very same thing, Dr. Finger, as to whether one would be so bold as to switch over to colchicine. Now, colchicine is a well enough tolerated medication that, you know, one could do a sort of a conversion kind of operation where you would start colchicine, get him up to a therapeutic dose of colchicine, which, at least based on the colchicine that's available in the U.S., would be 1.2 to 1.8 milligrams per day, and then slowly try to taper the azathioprine and see whether you would be able to do that without a flare of the disease. That would be how I would try it. I think it's at least an intriguing idea, but one would want to have to, given the history of this patient, one would want to approach it very gingerly.
Okay, so that answered one of the questions in the chat room, and in the interest of time, I think we are going to stop here, and I'll turn it over to the next case. Thank you so much, Dr. Finger. Thank you, Dr. Kastner.
Thank you. This was really terrific.
Okay, so our next case comes from Dr. Saldana at the Children's National Medical Center in Washington, D.C. And joining us as our senior mentor, we're very pleased to have Dr. Troy Torgerson, Associate Professor of Pediatrics and Director of the Immunology Diagnostic Lab at the University of Washington and Seattle Children's Hospital. And I'll turn it over to our moderator for the case, Dr. Shanmuganathan Chandrakasan.
Thank you. I think we'll just start with the case without much further introduction. Blachy, it's yours.
Sounds good. Thanks, Chan, and thank everybody else for inviting me. Hope somebody got the Bob Dylan reference from this. I was very proud about that. This is a case that came to us a few weeks ago. It's about a 2-year-old male who was previously healthy, had no issues. And he presented initially to his PCP with nausea, vomiting, and then abdominal pain. And all of these symptoms started shortly after he had gone camping. The family is from Central Virginia, and they had been camping in a lake in the forest near Central Virginia area. So the nausea, the vomiting, and the abdominal pain continued and actually worsened throughout time. And then a week or two after the initiation of those symptoms, he also started having headaches. And along with the headaches came some fevers. The fevers were initially low grade, and then slowly started to get higher and higher. So he was seen several times actually by his pediatrician, was prescribed a course of amoxicillin the first time around, had no improvement, actually worsening, and so came back. He had a course of cefdinir at that time that also did not help his symptoms. And so the nausea and vomiting progressed to the point that he was just not eating much at all. So he ended up being hospitalized in a hospital near his home for the inability to eat and for dehydration. This initial hospitalization was a short stay. He was there for only 2 to 3 days with hydration and some fever control. He felt better, so he was sent home. However, 48 hours after that admission, he was readmitted, this time to a different hospital, because of persistent symptoms. Basically, all of the symptoms were persistent and worsening. He was at that second hospital for around a week or so, in which they did several things trying to evaluate him. He actually, part of the evaluation actually included a scope because the nausea and the vomiting was so severe. Nothing was found on scope. And his symptoms progressed to the point where he developed shock, was actually intubated because of respiratory issues, and then was transferred to our hospital and to our ICU. So like I had mentioned, he was previously healthy. So before this, he had had no issues whatsoever. The family is originally from El Salvador. And like I said, he is 2. He had a 12-year-old brother who was alive and well, had never had any issues. Mom had had a previous miscarriage in between the 2 boys, but otherwise was healthy and had been fine. Mom also had 2 brothers, both of which were alive and well. Neither side of the family had any history of immunodeficiency or early death. No history of malignancies, and I should also note that no consanguinity either in between the parents. I'm going to stop there for a second in case anybody has any questions about the history.
Blachy, is there any consanguinity in the family?
No, no consanguinity.
So basically it looks like a 2-year-old with some GI focus, abdominal pain, diarrhea, then rapid evolved to a septic shock, multi-organ dysfunction, right?
Exactly.
And can you comment a little bit more about the rash?
Right. Let's do this. Why don't I go through the physical exam then, and then we'll tell you in a second. So okay. This was the exam by the time he came to our institution. So you can see he had some vitals that are consistent with shock. He was pretty tachycardic, a little bit hypotensive, high respiratory rate, poor oxygenation. He looked very acutely ill. He was a well-developed child, however, normal height, normal weight. No deformities were noted. He was intubated. You could actually feel some lymphadenopathy in his neck. And respiratory-wise, he had diffuse coarse breath sounds bilaterally with very noticeable increased work of breathing. And then the other part I want to highlight was his GI exam. He had very notable hepatosplenomegaly. So his liver was 3 centimeters below the costal margin, mid-clavicular line, and his spleen was even bigger at almost 4 to 5 centimeters below. You ask about the rash, Sean. So he had this very fine, mildly erythematous-looking macular rash, basically throughout the whole body. It had sort of a slight resemblance to petechiae, but sort of a little bit bigger, if that helps give you a good picture of that. And like this note, it was present throughout the whole body. Noted.
I think the audience brought up two infectious etiology, one ehrlichiosis and Lyme's disease. I think these are excellent differentials, but we still don't know the entire presentation, right? Do you want to comment on both of these, ehrlichiosis and Lyme's disease? Like within the spectrum, this can fit into septic shock, HLH, both infection-associated and non-infection associated. So what were the differentials you're thinking at this stage? At this stage, it's difficult to say this is immune or underlying immune deficiency or just an infectious diagnosis gone bad.
Right. No, actually, I agree with the ehrlichiosis comment. It's a great thought. That they can have the rash, they can develop a shock, and as you mentioned, they can have this HLH appearing presentation. So that was one of my initial thoughts as well. I have not, typically don't think of Lyme disease as presenting as quite severe, but again, it definitely could. And, in the area and the camping where he was doing, I think it's a consideration to have as well. But I agree with you. HLH was a big consideration. I see that somebody's asking for the ferritin values. So I'll give you some laboratories on the next slide. Rocky Mountain, okay, another good thought. So I'll go ahead and show you some laboratories then. These were the labs at presentation to our hospital. You can see his pancytopenic, hemoglobin was 7.1, platelets were 45,000. His white count looked okay, but his ANC was down to 900 by the time he presented to us, and this had been decreasing over time. I did find a CBC from his initial hospitalization. He was not pancytopenic, and he had a normal ANC. At this time, his lactate was quite elevated, as you can see, with very high retic. He had a mild coagulopathy here, as you can see, INR 1.5, PTT in the 45. A little bit acidotic in his chemistry. No liver inflammation, though. A little bit of a high bilirubin at 1.1. He had a slightly decreased fibrinogen and was Coombs negative. And then his chest X-ray did show ACR space and bronchograms, which I think were in keeping with early ARDS, consistent with the shock picture.
Just for discussion purposes, if you think this ANC is being persistently low, I just want the audience to, what would be the thought process if there is an underlying immune deficiency that you think of an ANC comes 500 or 400 or 900? What are the common immune deficiencies that can present as neutropenia in the absence of an acute infection? And I feel like based on the labs, though he's very inflamed, it doesn't seem to have caused liver enzyme elevation or other characteristic finding of HLH, right?
Right. His liver was not inflamed, which to me was not very consistent with HLH, but I still agree it's a worthwhile consideration. So that was one of the things that we pursued when he first got admitted.
Okay. I think let's proceed to the next slide. I think it's very difficult it's still an acute inflammatory process infection.
Here's a little of the autoimmune study. So you see here at your top right, ferritin was normal at 193, Trix were 131, and then during that second hospital admission in which he was evaluated for a week, they had done a mild immune workup. So I had at least I already had the knowledge of these laboratories by the time he came to us. So you can see here to his left his subsets. He was a little less pancytopenic when these subsets were done, but you can see that he had a good amount of cells, a little bit of a decrease here in his CD8, but all of his cells were present. And here with his immunoglobulins, you see a normal IgM, and he had quite drastically reduced immunoglobulins outside of IgM. So I'm intrigued to get how this changes your thoughts.
I think this is a very unique finding with an IgM that looks normal and with an IgA and IgG that is almost undetectable. I think one of the audience brought up hyper-IgM syndrome. Dr. Targerson or Blachy, do you want to comment on that? Try.
Okay.
Blachy, do you want to comment?
Yeah, sure. So I think that's a great thought, right? You have a child with normal IgM, otherwise no IgG, no IgA. He seems to have normal numbers of his counts by lymphocyte subsets. However, seems to be in quite severe shock. So I think with this presentation, it's definitely something that should be pursued. And I agree, that was one of my biggest concerns when I saw these values.
I think along the same lines, it will be helpful if they can also come up with differentials for either a normal or elevated IgM in the setting of low IgG levels. Again, going back to the audience, is there any other immune deficiencies they'll consider with normal or elevated IgMs and low IgG with predisposition for acute fulminant presentation?
Right, I see there some of the autosomal recessive functions. He did have quite noticeable hepatosplenomegaly. I think those are worthwhile consideration. PI3 kinase.
Yeah, I think those are really great trials. Both PI3 kinase delta or regulatory domain mutations, ataxatilyl-injectasia, and the recombinase defects. And even I've seen a couple of Nemo patients present with elevated IgM with low IgG. So that's pretty impressive. And is Troy online?
I am. Yes.
Do you want to comment on the immune profile? Yeah.
Comment on what? I'm sorry.
On this immune profile, like basically we have what looks like a normal lymphocyte subsets with a dramatically low IgA and IgG with a normal looking IgM.
Yeah, and I think the other piece that you need to take into account is the neutropenia as well, because this profile with normal or elevated IgM and then really low immunoglobulins otherwise, combined with neutropenia, especially in a male, should really raise alarm bells for hyper-IgM syndrome. Typically, the neutropenia occurs in the setting, oftentimes, of sort of acute infections and stress. And that's when they will drop their neutrophil counts out. So this is really a fairly classic presentation, at least in terms of the immune phenotype, for that. And I think as it was raised, I think that it really raises that diagnosis very high in the differential. All of the others that were brought up, I think, are certainly considerations. And in the setting of sort of an acute, some of those could be ruled out based on history. AT and radiosensitivity disorders. You'd expect maybe some other phenotypic abnormalities as opposed to this just sort of falling out with nothing else. Nemo, you might expect, of course, some ectodermal dysplasia, but although not always. But this sort of an acute presentation, at this young age in a boy, It really raises this diagnosis high on the list.
Thank you, Troy. I think we'll move to the next slide to see what we have.
Right. So this is just in summary. He's two sort of symptoms that he had presenting in shock in ARDS with us, and like we've commented, normal limb subsets, normal GM, otherwise hemoglobin. And then this is, I think, sort of the defining moment. 4 or 5 hours post-admission, his blood cultures were growing yeast. And so I think I won't be able to block it for you, but I have some pictures from his marrow here. So we actually ended up doing a bone marrow because of his pancytopenia, and the bone marrow grew the same thing that was in the blood culture. So this projects a little small, so you might not be able to see it as well as I wanted to, but right, this is a very normal looking marrow for the non-hemographers in the audience. There's no, there's tri-lineage hematopoiesis. You can see everything except for, I don't know if you're able to detect this round circular sort of lesions that I would say are sort of in the middle of the slide that seem very different from everything else. So these are the yeast forms with a halo around them. They have, this is CIS and music-harmon stain, which I don't know if there's any ID or PATH people in the audience, but they just show the fact that you have a polysaccharide cell wall, which is very in keeping with Cryptococcus, which is what he grew.
Just getting back to the pathogen, just curious, like the discussions thus far has been, this could be hyper-IgM. What this for the audience? What would be the differential if you have a fulminant Cryptococcus neoformans? I think a couple of things that are brought up. Stat1. Is Cryptococcus the one that you typically identify with hyper-IgM? Troy?
So this has been seen in hyper-IgM syndrome before, and in fact, a whole host of different fungal infections have been identified in hyper-IgM syndrome. The most common of those, of course, is pneumocystis, which we see frequently in those patients. But there was actually a lovely publication of the LACID from the LACID registry about their hyper-IgM syndrome patients. I thought that was really informative because, of course, many of the patients in South America are exposed to probably a lot more fungus than patients in other parts of the world, and that are less sort of tropical. And it was interesting in that report of the LACID registry that the spectrum of fungal infections that those patients got, and there were many more of them who had fungal infections than are typically reported in other case series of hyper-IgM syndrome. But I think it really highlighted the fact that this is a disease of fungal susceptibility that sometimes I think we don't appreciate how susceptible these patients can really be to fungus. And there's some really nice actually mouse studies specifically with Cryptococcus from back in the early 2000s where they were doing intrathecal injections of Cryptococcus in mice lacking CD40 ligand and saw really massive expansion of Cryptococcus in those mice and the fact that those that after the injection of the fungus the mice didn't generate normal levels of IL-12 and as a result didn't make enough interferon gamma to be able to control and clear the organism. So it's some really nice studies that show the susceptibility to fungal infection.
Thank you. Outside of this case, if you find a fulminant Cryptococcus, what other immune defects will you typically entertain in these patients, like anti-GM-CSF antibody and I'm just curious.
Although that's been mostly associated, with neurologic cryptococcus primarily. But yeah, I think that the suggestion of STAT1 was a good one. I'd be interested to sort of throw it back out to the audience and let people sort of chime in about other things that they might think about.
Like even the interferon gamma pathway defects, I think those are the ones classically known to be associated with cryptococcus, much more fulminant ones. And going back to the hyper IgM, the one that we are classically always thought about thinking is cryptosporidium. So do you want to briefly discuss cryptosporidium in these patients if this is hyper IgM?
Blachy, do you want to take a stab at that, or do you want me to take a stab at it?
Sure. So it's funny, I looked at that LAFIT paper right as this kid was coming into us. So that was part of what brought the differential to the top for me. But that paper also describes quite well the symptoms and the incidence of cryptosporidium in these patients. And so they seem to be very predisposed to it. It can cause some effect, but interestingly, the paper was also commenting on the fact that a good amount of the patients with cryptosporidium were also the ones that had big liver issues, namely ascending cholangitis and liver failure associated with it. Not all of the patients, but a significant amount of it. It is also a big consideration to have in these patients, and at least from the reports of that paper, it seems to be enough of a common phenomenon.
Yeah, and I would just add to that.
Go ahead. I'm sorry.
No, I was going to say, I would just add to that this is a big problem for these patients, and it's one that can be very difficult to diagnose because the stool specimens, looking for the cryptosporidial antigen and even doing PCR is really not a very sensitive test. So I would just as sort of a last thing, just remind people that if you're following any patients with hyper IgM syndrome, X-linked hyper IgM syndrome, that you ask them regularly about their stooling, about stomach cramps, abdominal pain, gassiness, those sorts of things, and that you screen them regularly for cryptosporidium. Sometimes, if they're having those sorts of symptoms, sometimes you have to screen them repeatedly, multiple stool samples before you find it. And occasionally, we've only found it on endoscopy, and so. And as Blachy points out, this is having cryptosporidial infection is a significant risk factor for developing the liver failure and other liver problems that these patients have. So it's really important.
Thank you, Troy. Can we just quickly conclude this case with the next slide?
So here you see the combination of the labs plus the cryptococcus drove us directly to flow for CD40 ligand. This is his actual test showing no expression of CD40 ligand after stimulation. So giving him the diagnosis of CD40 ligand deficiency.
Any last word on transplant, Troy, on these patients? We are running short of time. Maybe 30 seconds comment on transplant.
Yeah. So I think that the data from the two cohorts that have been collected and published, or maybe three cohorts now, is that that it certainly improves quality of life for patients, and it's not yet clear whether it improves long-term outcomes. Partly because I think that those patients haven't been followed long enough. If they're not transplanted, many of the patients, of course, will live into adulthood, and so once they're transplanted, I think we just don't know how much longer patients can live once they've been transplanted than without. So I think the jury is out. What I will say just very briefly is that for reasons that we don't entirely understand, transplanting CD40 ligand is tricky, and it's not terribly unusual to do the transplant and wind up with fairly low-level T-cell donor chimerism that may not sometimes be sufficient to support ongoing class switching, and then you're sort of back to ground zero. So there is some debate about bone marrow transplant in this disease because it's not quite as straightforward as other diseases.
Thank you so much, Troy. Thank you so much, Blachy. This is a wonderful case. Let's move on to the next interesting section of the webinar. The first in terms of insight into diagnostic immunology testing, and I'll let Andrew take over and present his slides. Thank you.
Okay, thanks, Shan. In the last 5 or 10 minutes or so, we just thought we'd talk a little bit about the key diagnostic immunology labs that we associate with diagnosis in these two very interesting cases we've heard today, at least an ALPS-related case and CD40 ligand deficiency. So we'll start with ALPS. We heard a little bit in the first case, and I think Dr. Notarangelo made some good points earlier that there are certain aspects of that case which aren't necessarily consistent with classical ALPS. And so if you look at the table on the left, you'll note that back in 2010, the NIH International Workshop revised the diagnostic criteria for ALPS. And the first two things you see there as sort of required phenotypes are a chronic lymphadenopathy or splenomegaly with a non-malignant, non-infectious lymphocytosis. And then, of course, an elevated double negative T cell count. These are TCR alpha beta positive, CD4, CD8 negative T cells. At the time, those were considered required, and a definitive diagnosis could be made if one additional primary criterion was met, either defective lymphocyte apoptosis, which we'll talk about in a minute, or the discovery of a somatic or germline mutation in the usual suspects, FAS ligand, and caspase-10. A probable diagnosis could be concluded with certain elevated biomarkers or histology, and I'll talk a little bit more about those in detail in a minute. So on the right side from the paper in Blood about the revised criteria, you can see this helpful sort of flow chart for diagnosing different forms of ALPS, which can be quite heterogeneous and lack complete penetrance. But certainly if you see chronic lymphocytosis with elevated double negative Ts, and a FAS mutation is found, that's the classic form of ALPS that we associate with about 70 to 80% of the cases. However, if a FAS mutation is not found, you can move down the list here to look for elevated biomarkers, somatic FAS mutations in sorted double negative T cells, et cetera, et cetera. So to move on, obviously, quantitation of double negative T cells is key, and I want to thank Dr. Abraham in particular for providing these very nice examples of typical flow cytometric staining. So if you look on the top, you'll see that if we gate on CD3 positive T cells and stain for CD4 and CD8, you can usually find a population of so-called double negative T cells. And in a typical pediatric patient, those constitute less than 2% of the total T cells. But if you then move down to the bottom panels, in contrast to the control, again, if we gate on CD3 positive T cells and we stain for CD4 and CD8 in the same channel versus alpha beta TCR, you can see in the patient that there's a sizable proportion of alpha beta positive T cells that lack CD4 and CD8 expression. The other key finding worth noting is that these double negative T cells also express the high molecular weight isoform of CD45 called B220, which you normally associate with expression on B cells, but Jack Bleesing many years ago showed that this is another characteristic marker expressed on double negative Ts from ALPS patients with FAS mutations. In more recent years, the value of these elevated biomarkers has become really critical. And this is illustrated best, I think, by a paper a few years ago from the group in Freiburg that showed if you look particularly at the combination of vitamin B12 and soluble FAS ligand, if you see elevated, those elevated markers above the cutoffs listed there on the left side of that left column, that can have a very strong positive predictive value for a patient that has a debilitating FAS mutation, 92%. And if those values are below the cutoffs, it's actually got a very powerful negative predictive value of 97%, that's not a FAS mutation. So what that group did, and I've included the link here, is actually created an online calculator where you can enter biomarker levels for B12 as well as IL-10 and soluble FAS ligand, and calculate a probability that a FAS mutation actually might be present. And I think, from what I understand, more and more centers are incorporating this measure as sort of a primary way of diagnosing ALPS or suspected ALPS. But again, I'll remind everyone that of course the defects we associate with ALPS are impaired lymphocyte apoptosis through the FAS death receptor pathway. On the left, you can see a cartoon of the FAS receptor. Normally, when that's ligated by FAS ligand, you induce a death-inducing signaling complex comprised of FAD and caspase 8 and 10, and of course that serves to activate those caspases and downstream apoptosis. If you look on the right, you can see a typical flow panel, the way we monitor cell death. On the top, an Xn5 staining, which is an early marker of apoptosis, versus propidium iodide, which gets into cells when membrane integrity is lost, and that sounds like the assay that Dr. Finger performed for the first case. You can keep it even simpler than that and look for PI staining just versus cell size, which is shown on the bottom there. So with regard to the kill assay, this is not really done routinely anymore, to my knowledge, at most centers because it's so labor intensive. So if you look on the left, typically to do this assay, you need to purify your PBMCs from blood, and then over the course of about 2 weeks, activate and expand T cells in IL-2, and then finally stimulate FAS with either recombinant FAS ligand or an agonistic antibody, we call APO13, and then analyze cell death by flow cytometry. And I've just shown an example. I won't go through this in a lot of detail. The normal way we would do this in a CLIA-certified kill assay is to collect cells on constant time on the cytometer and actually count the number of viable cells that are PI negative, and then get this cell loss calculation, which I've shown here on the bottom. The reason we do that is that's a little more accurate because, as most of you know, apoptotic cells tend to break up and fragment, and so that can lead to sort of skewed results in terms of what events are actually calculated by the flow cytometer. So by doing the cell loss calculation, it's pretty accurate, and you can see an example here in an ALPS patient with a classic FAS mutation, impaired FAS-induced apoptosis based on that calculation. Now, more recently, folks from Richard Siegel's lab and Mike Leonardo's lab at the NIH have developed a more rapid kill assay where you just take PBMC, stimulate with FAS immediately, and then sort of figure out by multicolor flow cytometry which cells are dying. And this is based on the premise that Dr. Siegel showed several years ago that effector memory T cells in the CD4 compartment are particularly sensitive to FAS-induced apoptosis right out of the blood. And so if you look on the right there versus the normal sort of range established in normal donors in the gray, patients in particular with intracellular mutations in FAS that affect the death domain, those tend to be the most debilitating, show a profound defect in FAS-induced apoptosis. So that can be helpful for a sort of a more rapid and cost-effective assay for cell death. So moving on to CD40 ligand deficiency, we saw that in the second case. The classic diagnostic flow cytometry is the measurement of the induction of CD40 ligand on the surface of activated T cells. This is based on an assay pioneered by Hans Ochs and colleagues in Seattle over 20 years ago. I pulled a figure from one of those papers where you can see if you take just fresh PBMC and activate them polyclonally with PMA and inomycin, you get a nice induction of CD40 ligand on T cells that's detected both by monoclonal antibody in panel A as well as a soluble fusion protein of CD40 fused to the FC portion of IG. And we'll get, in a minute, we'll get into why that's important. That's a test for functional binding. In contrast, if you look at this family with an X-linked hyper-IgM syndrome with a splice site mutation, you can see that CD40 ligand expression is severely attenuated, and that confirms the diagnosis. Obviously, when we're talking about CD40 ligand, we're focused on CD4 T cells. So often what's done is to gate on those T cells. Now, keep in mind that PMA9-myosin often leads to internalization of CD4, and so you can either stain for CD4 before you stimulate, or simply stain for CD3 and CD8 and gate on the CD8 negative T cells shown there with the blue arrow. And you can see if you focus on those CD4 T cells, you get a very robust induction of CD40 ligand on the surface in a normal healthy donor, whereas in hyper IgM syndrome with perhaps a deletion in CD40 ligand, basically there's no expression. Obviously in the carrier, this is X-linked, and you see sort of a nice bimodal distribution of about half the cells upregulating CD40 ligand. Of course, that's based on just random X chromosome inactivation in the female carrier. So I'd like to, again, thank Dr. Abraham for these really nice slides that illustrate this point about differentiating CD40 ligand expression from impaired function. And so in about 80% of the cases, indeed, you see absent expression. If you compare the normal donor on the left side versus the patient on the right, you can see that neither the monoclonal antibody nor the soluble fusion protein of CD40 is detecting any CD40 ligand, indicating likely something like a deletion. And on the bottom, you'll note CD69, which is an early activation marker for T cells. That's important to include because it's a control for your stimulation to make sure your T cells are stimulated properly. And then finally, in about 20% of these cases, expression will actually be intact as detected by the antibody on the top row there. But when you look for actual binding to CD40 using the fusion protein, that is impaired. And that's shown here nicely in example mutation T147N, which impairs that CD40-CD40 ligand interaction. So with that, I'll end there. If anyone has questions regarding these assays, feel free to ask, and I hope that was helpful. I know we're running close to time. Well, if there are no other questions, let me thank both our presenters and our esteemed senior mentors for joining us. I think that was a terrific conversation of both cases. Again, I'll remind everyone that participated tonight to please remember us and send some interesting cases our way. We're always looking for new cases to present in subsequent webinars. And I'd just like to thank my co-moderators and, of course, CIS as well. And with that, I think we'll conclude. So we'll see everyone next month.